Thanks, Jared. And thanks everyone for joining us today. Today, our senior fellow in the department is going to be presenting a very important case presentation and also a very important topic, I think, that's relevant to our physicians, our junior registrars and interns as well, a case on primary aldosteronism. Brett actually has a special interest in the diseases of the adrenal gland, so I think that's probably why he even chose this topic. But I think it's important not only because it's the most common secondary cause of hypertension, but rather because despite this disorder being the most common cause of secondary hypertension, it still remains largely underdiagnosed and even undertreated, where about 1 to 1.5% of the adult population with secondary hypertension, or rather resistant hypertension, are still only being screened appropriately. So I think it's important to understand the disease physiology and also to understand how to go about screening. And I hand over to you, Brett. Just a reminder again to fill in the attendance register, post your questions in the chat box, and hopefully we can have a stimulating discussion after. Brett?
Great, thanks, Farzahna. Thank you for having me talk this morning. So as Farzahna mentioned, I'm going to be discussing a topic of which I have a particular interest, that being primary aldosteronism. And I'll start off with a clinical case. And this is a case that is not particularly unusual, and I'm sure many of you would have encountered a similar case in your time. This was a patient that we saw last year at Charlotte, a 46-year-old male. He had been referred to endocrinology with poorly controlled hypertension. And this was despite treatment with 3 antihypertensive agents, being a calcium channel blocker, a thiazide diuretic, and an ACE inhibitor. He was asymptomatic. He reported no headaches, sweating, palpitations, had no history of chest pain. He reported no muscle spasms or cramps. Equally, there was no weakness. He was not on any other medications, which could potentially worsen his hypertension. He had no other comorbidities and reported no history of cardiovascular events. He was of sober habits and denied any illicit substance use, and there was no family history of note. His blood pressure was notable for what was stage 2 hypertension. He was slightly overweight, but otherwise his exam was unremarkable. There were no clinical features to suggest an endocrinopathy as a secondary cause. So his initial blood results revealed a moderate hypokalemia, and this is what raised further suspicion for primary aldosteronism. And I'll tell you about a similar case, perhaps a bit more extreme, but this was reported more than 70 or almost 70 years ago. And this was by Jerome Conn and Lawrence Louis, who described in a case report a 34-year-old housewife who had repeated attacks of generalized muscle weakness as well as muscle spasms. Her blood pressure was markedly elevated, and she had a hypernatremic hypokalemic alkalosis, which further characterized the syndrome. The muscle weakness could be explained by the hypokalemia, with muscle cramps being explained by hypocalcemia from severe alkalosis. So Jerome Conn and his colleagues thoroughly investigated this woman for a period of 227 days, most of which she was admitted. And I'm sure Prof. Mohamed would be quite unhappy if endocrine was to do the same. They investigated her by measuring sodium and chloride in her sweat. They did sodium-potassium ratios in saliva. They observed her daily serum sodium, potassium, and pH values. They measured stool and urine potassium. They strictly monitored her intake. Eventually, they concluded that the syndrome had to be due to excessive aldosterone secretion. And at the time, they couldn't measure aldosterone, but they still recommended bilateral adrenalectomy after 227 days. And at surgery, to their surprise and delight, they found that a tumor was present on one adrenal gland. And this was the first description of an aldosterone-producing adenoma. So fortunately for us, we could investigate the patient a little bit quicker, and were able to measure renin and aldosterone. Clearly his renin was suppressed and aldosterone markedly elevated, resulting in an aldosterone-renin ratio which was very high. So Conn's syndrome, as it became known at the time, was characterized by the classic triad of hypertension, hypokalemia, and metabolic alkalosis. However, this represents the more extreme form of the condition. It wasn't long before Jerome Conn described milder cases of hypertension with normokalemia, and it's these milder cases that frequently go unrecognized. Indeed, only 9 to 37% of patients with primary aldosteronism are hypokalemic. But it's the presence or absence of hypokalemia that often determines whether most clinicians think about or even decide to screen for the condition. So by 1964, after diagnosing more than 145 cases of primary aldosteronism, Jerome Conn suggested that 20% of patients with essential hypertension, as it was called, might have primary aldosteronism. The medical community at large felt this was a gross overestimate, and he later revised this prevalence estimate to around 10%. More recently, studies which are very heterogeneous and encompass both primary care and tertiary referral centers put the pooled prevalence at around 5 to 13% of all hypertensive patients. This number increases to around 20% and even more in some studies in patients with resistant hypertension. This makes primary aldosteronism the commonest commonest endocrine cause of secondary hypertension. So a couple of years ago, Brown and colleagues performed a study which demonstrated a spectrum of elevated aldosterone secretion, which spans across varying blood pressure categories, including normotension. And this figure demonstrates that. This is in patients who have a suppressed renin. And clearly you can see that with increasing degrees of blood pressure, the higher the rates of detection of primary aldosteronism. So based on a conservative definition of excessive aldosterone excretion, prevalence estimates for primary aldosteronism ranged from about 5.9% in the normotensive cohort, and this went up to as high as 38% in the group with resistant hypertension. So aldosterone is the main mineralocorticoid in man. It circulates 50 to 70% circulates bound to albumin, while the remainder circulates free. It has quite a short half-life of around 15 to 20 minutes and is rapidly inactivated in the liver. Aldosterone secretion is regulated by three main factors. This is angiotensin II, extracellular hyperkalemia, and ACTH. The principal functions are regulation of extracellular volume and potassium homeostasis. And this is through effects on the distal convoluted tubule in the nephron of the kidney, where mineralocorticoid receptors are highly expressed. Receptors are also found in the gut, the heart, and parts of the brain. So the classical effects then are potassium homeostasis and extracellular volume regulation, but there are also a number of non-classical effects, this being the expression of collagen genes, as well as genes controlling tissue growth factors and those mediating inflammation. So the adrenal gland is divided into an inner medulla and an outer cortex, with the cortex being further subdivided into the zona glomerulosa, zona fasciculata, and zona reticularis. And aldosterone is secreted from the zona glomerulosa, and it's confined to this region due to the zone-specific expression of 11-beta hydroxylase type 2, also known as aldosterone synthase. So when there's a decrease in intravascular volume and glomerular filtration, this is sensed by a reduction in the delivery of sodium and chloride to the macula densa. And this promotes the release of renin by juxtaglomerular cells. Renin then catalyzes the cleavage of angiotensinogen to angiotensin 1. And this is converted to angiotensin 2 by angiotensin converting enzyme. So angiotensin 2 has a number of actions. It leads to vasoconstriction to maintain arterial pressure. It increases sodium reabsorption in the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. And this results in the majority of filtered sodium being reabsorbed prior to the distal nephron. And this leads to decreased delivery of sodium. This leads to decreased delivery of sodium to the distal convoluted tubule. Angiotensin 2 also obviously has stimulates aldosterone secretion, which has effects on the principal cells in the collecting ducts. The aldosterone acts on mineralocorticoid receptors to influence sodium reabsorption via the ENaC channels, the epithelial sodium channels in the collecting duct. In exchange for sodium, potassium and hydrogen are excreted to maintain electroneutrality. Hyperkalemia is an independent stimulus of aldosterone secretion. High potassium leads to depolarization of the zona glomerulosa cells and secretion of aldosterone. And this activates the mineralocorticoid receptor and stimulates the ENaC-mediated sodium reabsorption in the principal cell. And this process again promotes potassium excretion. In the setting of volume expansion, angiotensin 2 is suppressed and proximal tubular sodium reabsorption is decreased. So the delivery of sodium to the distal nephron increases, and this results in the excretion of more potassium. So the net effect is an increase in urinary potassium while minimizing the reabsorption of sodium. Excuse me. So in primary aldosteronism, there is an autonomous renin-independent aldosterone secretion occurring from one or both adrenal glands. And this leads to increased stimulation of the mineralocorticoid receptor in principal cells, leading to an inappropriate reabsorption of sodium via the ENaC channel with loss of potassium and hydrogen ions. Reabsorption of sodium leads to expansion of the intravascular volume, which results in suppression of renin and angiotensin. Reduced angiotensin 2 leads to a reduction in sodium reabsorption in the proximal convoluted tubule, as well as the loop of Henle. And this leads to an increase in the distal sodium delivery, and as a result, a vicious cycle ensues. So the net effect is really volume expansion, an increase in blood pressure, hypokalemia, and metabolic alkalosis. So who should we screen for this condition? These are the patient groups in which the prevalence of primary aldosteronism is known to be relatively high. Many physicians are aware of patients who develop hypertension at a young age, or those who have hypertension in the presence of adrenal incidentuloma, as well as patients who have resistant hypertension, that being poorly controlled blood pressure on 3 or more agents. However, I just want to highlight those patients who have sleep apnea, as well as those who have hypertension controlled on 4 or more agents. We would also consider screening these patients. Patients who we should not screen, well, older patients with normokalemia and mild hypertension, or patients controlled on a single agent. But in spite of these recommendations to screen in these groups, screening and case detection remains low and is a worldwide problem. And this was shown in a study published recently, which evaluated the testing rates for primary aldosteronism over a 17-year period. And the screening rates are that line, which is somewhat parallel to the x-axis near the bottom, representing screening rates of around 1 to 2% of all patients with resistant hypertension. And clearly we're identifying more patients with resistant hypertension, but screening even less. But why even diagnose primary aldosteronism? So aldosterone has excess, has adverse cardiovascular events which extend beyond hypertension, and specific treatment against aldosterone excess reverses this cardiovascular morbidity. The long-term cardiovascular outcomes of 54 patients with primary aldosteronism were compared to 323 with essential or primary hypertension. Patients had similar blood pressure control over 7.5 years, but patients with primary aldosteronism had a more than 2-fold increased risk of myocardial infarction or reversible ischemia, and a more than 4-fold increased risk for stroke or sustained arrhythmias, mostly atrial fibrillation. There was no difference in peripheral arterial disease. In another study, this was a multi-center longitudinal cohort study with over 900 patients with untreated hypertension. They found a linear association of coronary artery calcium score, this being a marker of subclinical atherosclerosis, with rising plasma aldosterone concentration. And this association became more prominent when the groups were stratified according to whether renin was suppressed or not. So many studies have consistently shown the association of primary aldosteronism with cardiovascular disease. The best evidence for cardiovascular morbidity came from a meta-analysis of 31 prospective and retrospective studies, which involved over 3,800 patients with primary aldosteronism and more than 9,200 patients with essential hypertension. And those patients with primary aldosteronism had a significant risk of stroke, coronary artery disease, atrial fibrillation, heart failure, left ventricular hypertrophy, as well as diabetes and metabolic syndrome. And these long-term adverse cardiovascular events occurred irrespective and independent of blood pressure control. When screening for primary aldosteronism, the aldosterone-renin ratio is the most reliable test and is better than measuring renin or aldosterone in isolation. The plasma renin activity involves the measurement of angiotensin 1 generated by, from angiotensinogen by the action of renin, whereas the direct renin concentration, which we measure in our lab, is just that, a direct measurement of renin. So the aldosterone-renin ratio greater than 75 is suggestive of primary aldosteronism. And although it's the most sensitive initial screening test, there are a lot of problems. A number of false positives may occur from a number of drugs, including beta blockers, alpha-methyl dopa, non-steroidal anti-inflammatories. And these occur from decreased renin as a result of the action of these drugs. False negatives may occur from the stimulation of renin. The exception of this is obviously hypokalemia, which, as we've mentioned, affects aldosterone concentration independent of renin. So the recommendations then before performing an aldosterone-renin ratio are to correct the hypokalemia. The patient should be on unrestricted salt intake. Diuretics, including mineralocorticoid receptor antagonists, should be stopped for at least 4 weeks. One should stop beta blockers, methyl dopa, clonidine, non-steroidal anti-inflammatories, as well as ACE inhibitors and ARBs for at least 2 weeks. Blood pressure can be controlled with other medications such as hydralazine, verapamil, and doxazosin. Samples should be taken in the morning when the patient has been ambulant for more than 2 hours and then seated for more than 15 minutes. But this really makes screening for a common disease rather complicated. So really the best time to test is at the time of the patient's encounter. And this minimizes the burden on patients and clinicians. We can be aware of the effects that certain drugs may have on the aldosterone-renin ratio, but most of the time these are not clinically significant changes. The ones that are important are mineralocorticoid receptor antagonists, as well as ACE inhibitors and ARBs. So spironolactone antagonizes aldosterone from activating the receptor. This leads to sodium loss, decreased plasma volume, and this increases the plasma renin activity or concentration. This reduces the utility of the aldosterone ratio. So for patients who are not yet on mineralocorticoid receptor antagonists, this is the best time to measure it. Screening can still occur in patients who are on spironolactone but are still hypokalemic. And this suggests that mineralocorticoid receptors are not fully blocked. If renin is suppressed, no matter what the medication they're on, we can still interpret the aldosterone level and the aldosterone-renin ratio. If the renin is not suppressed and the pretest probability is high, it's at this point that you can perform a drug washout over a period of 4 weeks and repeat the test. Patients who screen positive for primary aldosteronism should undergo a confirmatory test, of which there are a few to choose from. The limiting factor for the oral salt loading test is our inability to measure 24-hour urine aldosterone. The fludrocortisone suppression test is regarded as one of the most sensitive tests for establishing the diagnosis, but requires a patient to be admitted for a period of 4 days and is quite labor intensive. We have performed this test at Charlotte, that was last year. The saline suppression test is the most commonly used test, and this is an infusion of 2 liters of normal saline over a period of 4 hours. Renin, aldosterone, potassium, and cortisol are drawn at the beginning and after 4 hours. The test, however, is contraindicated in chronic kidney disease and heart failure. And following this sodium load, a post-infusion aldosterone less than 140 rules out primary aldosteronism, while a level greater than 280 makes primary aldosteronism more likely. The Captopil challenge test is another test but is less used, as Captopil is not readily available, although Endocrinology at Helen Joseph have been using this test of late. So all tests suppress normal physiological secretion of aldosterone. So a failure to suppress aldosterone is indicative of renin-independent autonomous aldosterone secretion. And there is a caveat in that patients who have a suppressed renin, spontaneous hypokalemia, that is a potassium less than 3.5, and a markedly elevated aldosterone above 550, is diagnostic of primary aldosteronism. There are no differential diagnoses for this setting, and patients do not require a confirmatory test and can proceed directly to imaging. So going back to our patient, he underwent a saline suppression test, although he did meet that caveat. And at baseline, although on a blood gas his potassium was normal, his formal potassium was in fact low. And clearly you can see his aldosterone didn't get anywhere near to ruling out the diagnosis. So it was the diagnosis was confirmed. Following a positive confirmatory test, the next step is to determine the subtype of primary aldosteronism. Aldosterone-producing adenomas are the prototypical Cons syndrome. Patients tend to be younger, they have more resistant hypertension, and more likely to have hypokalemia. Aldosterone-producing adenomas represent 30% of cases of primary aldosteronism. More commonly, in around 60% of cases, bilateral idiopathic hyperplasia of both adrenal glands is present. And these two forms make up the majority of cases. There are other rarer cases of primary aldosteronism, such as unilateral adrenal hyperplasia, aldosterone-producing adrenocortical carcinoma, and then some familial forms, as well as some ectopic aldosterone-producing adenomas or carcinomas. Following confirmatory testing, subtyping begins with a CT scan of the adrenals, and there are only a few outcomes. The CT scan will either be normal, there may be a very large adrenal mass, and something greater than 4 centimeters would be suggestive of an adrenal carcinoma. And then there would be either unilateral micro or macroadenomas or hyperplasia, or bilateral micro or macroadenomas or hyperplasia. Unfortunately, though, CT scans are not accurate for lateralizing primary aldosteronism. And this is because with age, typically over the age of 35 or 40, the incidence of incidental adrenal tumors, most of which are benign and non-functional, increases. Adrenal incidentalomas are present in around 2% of the general population. This number increases with age to around 7% in those over the age of 70. Importantly, autonomous secretion of aldosterone may occur within very small, sometimes sub-centimeter foci within the adrenal glands, and these may not be visible on CT scans. And this is where adrenal vein sampling comes in. So adrenal vein sampling is the gold standard for determining whether primary aldosteronism is unilateral or bilateral. It requires a fair amount of skill and is usually performed by an interventional radiologist or a cardiologist. Samples of aldosterone and cortisol are obtained from both adrenal veins and the inferior vena cava. And from these, we're able to determine a lateralization index and contralateral suppression index. These are ratios which assist us in working out whether it's unilateral or bilateral. Unfortunately, well, there are a number of contraindications. So patients who are not surgical candidates, those with who should not receive contrast, patients who have significant comorbidities and would not be eligible for surgery, or patients who simply refuse surgery. Of course, patients who have an adrenocortical carcinoma, which would be diagnosed or suspected on a CT scan, would not proceed to adrenal vein sampling. They would go straight to surgery. Patients should be prepared before adrenal vein sampling. We would discontinue mineralocorticoid receptor antagonists for 4 weeks, ACE inhibitors and ARBs for 2 weeks, and diuretics and beta blockers for a week. And before the procedure, we would ensure that the patient has a normal potassium. In one study, they performed CT scans and adrenal vein sampling in 203 patients, and they evaluated the concordance or discordance of unilateral or bilateral aldosteronism. So CT scan correctly identified unilateral or bilateral disease in 103 patients, about 53%. And those are the filled-in symbols, the dark symbols. This was out of a cohort of 194 patients that had successful adrenal vein sampling. So CT scan was only accurate in 53%. So that's as good as a flip of a coin. So we definitely need adrenal vein sampling. CT falsely suggested an aldosterone-producing adenoma. So this would have been a non-functioning benign adrenal nodule in 48 patients. So these patients would have gone for inappropriate surgery. CT also inaccurately suggested bilateral hyperplasia in 43 patients who actually had unilateral disease. So CT scan is really not good in deciding on whether the patient should go for an adrenalectomy or not. So back to our case, a contrasted CT scan revealed a 1 centimeter round nodule in the right adrenal gland, and the washout was consistent with an adenoma, and the left adrenal gland appeared normal. Unfortunately, at the time, adrenal vein sampling was not available for us. There are only a few interventional radiologists who are able to do this procedure. So the options were discussed with the patient, given the risks that this may be a non-functioning adenoma and that there may be secretion of aldosterone from the contralateral adrenal gland. The patient understood this and opted to go for a right laparoscopic adrenalectomy. Fortunately, 2 weeks post-operatively, his blood pressure had normalized. He was now on a single agent. His renin and aldosterone were normal, as was his ratio, and his potassium had normalized without requiring potassium supplementation. But why should we go to all this trouble? Why don't we just put everyone on spironolactone? Wouldn't that be easier? The Pathway 2 trial was a double-blind crossover randomized control trial, which lasted 12 months. And this study was designed to evaluate the optimal fourth-line agent for the treatment of resistant hypertension. They compared spironolactone to bisoprolol, doxazosin, and placebo. 330 patients were enrolled with resistant hypertension, and 230 cycled through each of these drugs. And clearly the addition of a fourth agent was superior to placebo, but spironolactone was better than doxazosin and bisoprolol in terms of blood pressure control. It led to a 12.8 millimeters of mercury reduction in systolic blood pressure compared to 8 for doxazosin or bisoprolol. But this spironolactone was better when renin was suppressed, suggesting that some of these patients with resistant hypertension actually did have primary aldosteronism. This was demonstrated quite nicely on this graph, where you can see that spironolactone, which is the red line, achieved about a 20 millimeter of mercury drop in blood pressure in patients who had a renin which was lower than 1. In another study evaluating cardiovascular outcomes in medically treated primary aldosteronism, the incidence of cardiovascular events was still higher in patients with primary aldosteronism treated with mineralocorticoid receptor antagonists as compared to patients with essential hypertension. And as I mentioned earlier, they had higher risks for mortality, diabetes, and atrial fibrillation. Importantly, though, in this study, almost 90% of patients had, in patients who had a renin that was suppressed, the mortality was similar to those with, these patients had renin, 90% of these patients had a renin which was suppressed. So the authors suggested that up-titrating mineralocorticoid receptor antagonists to doses where renin was not suppressed would result in outcomes which are similar to those with essential hypertension. So the rates of development of chronic kidney disease were also greater among patients medically treated for primary aldosteronism, with a much lower incidence in those who were able to go for surgery, those with unilateral primary aldosteronism. And there is a consistent cumulative increase in the incidence of CKD in those who are medically treated compared to those who underwent surgery or those with essential hypertension. So then the management for unilateral primary aldosteronism is adrenalectomy. And this is better than treating with medical therapy. Preoperatively, blood pressure control and correction of hypokalemia with mineralocorticoid receptor antagonist or potassium supplements should be done. There are a number of predictors of success. Females, patients who are younger, those who don't have left ventricular hypertrophy, as well as those on fewer antihypertensive agents are more likely to have a clinical and biochemical success. Post-operatively, we would measure aldosterone on day 1, and if it falls below 140, it suggests cure. At the time, we would also discontinue mineralocorticoid receptor antagonists as well as potassium supplements. We would monitor for hyperkalemia in hospital and once weekly for 4 weeks. Patients may suffer from transient hypoaldosteronism, and this is due to chronic suppression of renin and contralateral adrenal gland aldosterone secretion. We would also monitor renal function. The correction of aldosterone excess may decrease renal hyperfiltration and unmask underlying renal impairment. And some studies have found that GFR declines by an average of about 13 mils per minute following removal of the aldosterone excess. In patients with bilateral primary aldosteronism, the goals are the same for unilateral disease, although patients obviously can't undergo surgery. But we would aim to control blood pressure, correct hypokalemia, and reverse or prevent cardiovascular consequences. And this is done by introducing a mineralocorticoid receptor antagonist, usually spironolactone. But importantly, we should aim to uptitrate this drug, uptitrating it until there is no hypokalemia and until renin is not suppressed. And you can see this on this algorithm, where following introduction of spironolactone at 25 milligrams per day, you would monitor blood pressure and potassium after 7 to 10 days. If blood pressure is still elevated, but potassium is low, that's on the left-hand side, you would increase the dose of spironolactone. If the blood pressure is still elevated, but potassium is greater than 4.5, you could add a non-mineralocorticoid receptor antagonist antihypertensive medication. If the blood pressure is less than 135/80, but potassium is greater than 3.5, you could continue with treatment. You're at goal. If blood pressure is less than 135/80, but potassium is low, you would reduce other antihypertensive medications, but increase spironolactone in a stepwise manner. Importantly, and this is something that we often don't do in patients who are medically treated, is to measure renin after 3 to 6 months. And the importance of this is to make sure that renin activity is not suppressed. So again, the goals are prevention of morbidity and mortality associated with hypertension, the correction of hypokalemia, and the prevention of cardiovascular disease and chronic kidney disease. But importantly, normalization of blood pressure is not the only goal. We have to normalize circulating aldosterone by instituting a mineralocorticoid receptor blockade. And this is just another algorithm which looks at the diagnosis of primary aldosteronism, trying to minimize or stop us from focusing so much on the aldosterone-renin ratio, but focusing a little bit more on a suppressed renin. So in patients who have a suppressed renin and aldosterone is greater than 420 in our units, this would be an overtly positive screen. and in patients who have hypokalemia, this would confirm the diagnosis. If renin is not suppressed, moving to the exclusionary pathway, then this makes a primary aldosteronism unlikely. When renin is suppressed, moving down the middle of the screen, and aldosterone falls between about 140 to 420, this is still a positive screen, and we would proceed to confirmatory testing to try and rule in or rule out primary aldosteronism. So in conclusion, primary aldosteronism is a common cause of hypertension, despite previous thoughts. It's frequently under-recognized. The rates of screening are very low, and this leads to significant underdiagnosis. Early detection will minimize the consequences of the disorder, and these being stroke, left ventricular hypertrophy, atrial fibrillation, and chronic kidney disease. And these consequences are greater than for essential hypertension and independent of blood pressure. Screening with the aldosterone-renin ratio is the most sensitive, but it's important to know about the drugs which may influence this ratio, and you should always have a suppressed renin when making the diagnosis. Laparoscopic adrenalectomy is superior to medical therapy in patients with unilateral disease. However, when mineralocorticoid receptors are used, so in patients who are inoperable with unilateral disease or who have bilateral disease, the dose of spironolactone should be up-titrated to ensure that renin is not suppressed. Thanks very much for your attention.